Well, welcome to a magnificent cold Friday. I hope you're enjoying the cold. If you're not, I feel sorry for you. But hopefully you learn to enjoy the cold. There's a magic to enjoying the cold. You just let it into your body, and if you're not really freezing, you can live with it. You can do cold training. That'll help you for sure. It won't fix the problem, but it'll help. Um, yeah, so I guess it's kind of a half hypocritical what I'm saying, since I grew up in a freezing environment, and I didn't have a choice in the matter, so I kind of just learned to cope with this. But nonetheless, I think we can learn to tolerate weather through different methods. Anyway, but I totally get it if you rather just totally be cushioned nicely and warmed up with different layers and sat on your couch in front of fireplace watching a TV. That feels like that's what we want to do. But anyway, so again, welcome everybody. So we have a lot of small things today. I'm gonna start with keeping up things from the last week. Um, First of all, I posted something in the chat, and I'll probably post a couple more times as people keep arriving. So if you're interested in the whole topic of legalization of drugs, or particularly, well, not drugs, I'm talking about psychedelics and cannabis, do feel free to join this free event. It is in person on campus on next Tuesday at 5:30 p.m. It's open to public, even though you will see it's not like heavily advertised for general public, but you guys so special, we decided we'll advertise it for you, so you can come and join us. It's going to be interesting. It's not really a debate, it's more of a conversation. So there's a head of ethics at GW. There is a former alumni who's now in a cannabis industry as one of the venture capitalists and investors, and then me as kind of a more of a medical side of things. So it should be interesting conversation between sort of balanced. Obviously, ethicist is very concerned about side effects and toxicity, and then generally implication to a public. Of course, the cannabis industry partner wants to see the money flowing, and then I'm kind of have more of a medical eye on the things. And it's at the beautiful facility. It's up at the top floor, overseeing entire mall from back of GW, one of the Congress halls there on top. So feel free to check. They're trying to do the virtual option. I have a feeling that they're not going to get themselves organized. I'm not sure what the hurdle is. But you can, if you want to come and you only want to come to virtual, which of course I understand you may not want to go to large gathering, but keep an eye on the website. They told us that if they will set this up today or Monday, they'll have a link to a registration for Zoom. So that's the first thing. Now let's go back to a hot discussion that Rona and I had last time. I do really appreciate we had this discussion because it forced me to learn my own shit and realize that I was wrong. Well, I was partially wrong. How about that? So the reality goes like this. It's 100% correct that if a physician's office does not have a pharmacy on site, they're not allowed to dispense vaccines. They can't administer them through the insurance. But a lot of offices, including GW, bypass them. They will, because GW has a pharmacy on the first floor. So they're basically saying, because of that, every floor has a pharmacy, quote unquote, and thus it's fine. It's like administered in the clinic at GW as if it's an actual pharmacy dispensation. But it is a different parts. So the drug part will cover vaccine, and then the office is different parts. So if for some reason you don't have one of the parts, you may actually not get that covered at all. And then you show up to the doctor's office, they may not know, they'll give you a shot, and then you're going to get a bill. So I think that's what Rona was trying to say last time. And that's actually 100% accurate. So you need to know whether or not you have the appropriate coverage for the vaccine. That's first. And second, if you're trying to get the vaccine in your office, you need to ask the office manager whether they have that pharmacy license to distribute vaccine in the office. And if they don't, tell them, okay, no, but no, thanks. And I'm going to go to my pharmacy to get the vaccine, and then it will be fully covered. So that's the clarification. And again, thanks for that. And by the way, never worry about confronting me, because I could be totally wrong on all kinds of things, and I'll take that into consideration, and that's how we all learn together. So really appreciate that. Okay, so that was one. Rona bringing up interesting point about advanced directives. So It's a really important topic. I hope everybody understand what this is. Sometimes the words that are used are living will for healthcare decisions. Sometimes we use this universal word, which is kind of a more neutral word, which is I prefer. We call them 5 wishes. I don't know if everybody heard this. So the idea is that it's kind of more neutral. Advanced directives sometimes gets a pretty bad rep, the wording, because it's like usually if you're in a hospital, they just say, oh, it just means DNR, DNI. It doesn't only mean DNR, DNI. It's much more comprehensive ethical document that positions how you view if something bad happens to you and you're unaware of your environment and your body is deteriorating and somebody needs making decisions for you, and it's not just about DNR, DNI, it's about everything. It's about how do you see your last months and years of living and what's important for you. So I want to make sure this is highlighted. Now, there are a couple of ways you can do this. You can purchase for, I think, about $30. And let me see if I can quickly find. Actually, Umer, you here? Dr. Ashraf may be going to help us because I can't talk and search at the same time. Umer, can you Google the 5 Wishes official website and just drop it in the chat? So that's oh, perfect. That was fast. Thank you. So now it's a fee service. It's a low cost. It's like $30. If you're one of our GW patients, we often keep the paper copies in the office. We'll just hand them to you. And then you don't need a lawyer. You need a lawyer if you're in a like New York State. There's like 5 states where you have to have a lawyer or not notary to sign. Otherwise, you really don't. You need 2 witnesses on the document. And then you really need to think through about all the outline and address all the questions. But the most important thing, you really need a designated next of kin, or sometimes we call it power of attorney, although power of attorney typically means more legal statement. Next of kin would mean who do you want to make decisions for you, right? Now, it's really critical to understand that that person does not have to be your relative, okay? Everybody's think, oh, it has to be a relative. No. I mean, you may have some good friend or maybe your lawyer or your neighbor who knows you better and who understands you a lot better than some of your relatives. And it's totally acceptable that that person would be the person you put into the advanced directives, into the 5 wishes. Let me post something from YouTube. So I did this video with Chris Palmer, who's going to be coming here. Janet, I think it's in January, right? Mid-January. Is Chris coming to us?
Yes.
Something like that. And I'm sorry if we a little off on timing. Maybe it's in February. We don't remember. So Chris and I recently did a YouTube video. He published this book. I don't know where it is. It's somewhere around here. On death and dying, and it's a very interesting book. And he spent a whole chapter on how do you do the advanced directives, and he kind of normalizes it to the point of how do you do this well, and how do you do this way in advance? Because one of the big problems is we tend to often think that this document has to be done, days or weeks before you pass. That is really wrong thought process. This document has to be done pretty much as soon as possible, and even if you're in your 30s or 40s. Now, you don't have to do the full document, but what's critical is that there is someone you name who will make those decisions for you if you can't make them, and that person is fully understanding what do you want. Whether that's fully documented or not is it's still important to some degree, but it's more important that you simply know who that person is, you talk to that person, and you told them what to do. All right. And I fully grasp how difficult this conversation is. This is one of the most difficult conversations you're going to have with friends and relatives. And yet it's really, really, really important. So if you care about this topic, you can tune to the video and definitely come back when Chris comes, because it'll be really interesting to hear the way he presents. He's an advocate for kind of a palliative care field, and he's really good about this. So, Ron, is this okay, or do you need any more help? I mean, you may need something more specific to you, since I don't know exactly what the problem was. We can't hear you because Janet made everybody muted. So Janet, can you, oh, here, see if that works. Can you try to unmute yourself now?
Okay.
There we
Hi.
go.
Can you hear me?
Yeah.
No, my lawyer gave me the form
All right.
and I just have had trouble filling it out. I've had trouble. It's too simplistic. It needs more details. It needs better definitions of the wording. And then on top of that, it's really hard to figure out. It doesn't have any time lengths, for example. Like, do you want to
Yeah.
have these things done for a few months, for a few
Yeah.
years?
Yeah.
So
Yeah.
it's like
Yeah.
incomplete and difficult.
Yeah. Yeah. I hear you. And you're gonna feel like this about almost any template you'll be given, because unfortunately, if you think about this, you can't predict any possible scenario that may happen, and that's part of the problem. So it's an innate struggle with any of these documents. It's
Yeah,
more important that you simply think through, and if you feel there's something missing, you should just add it in. The beauty of Five Wishes, you get this digital document, and if you feel strongly, I disagree with this, I'm going to cut it out. You just cut it out. You get PDF file, or like there's an editable format, and you can edit this on your own. You don't have to go with what lawyer give you. Lawyers sometimes give you like their own forms that they got from some low society here and there from 50 years ago, and the document may be a bit dated. And also like they obviously want you to go back to them, so you pay them to sort of sign the document and all that. It's up to you. If you have a great relationship with a lawyer, there's nothing wrong with that. But my take on this is you don't really have to have. We're not required in the DMV area to have a legal the signing. Just witness is sufficient as long as
I'm
long.
okay doing it with the lawyer, but I just don't like the document. I'm not happy with it.
So just modify it and go back to lawyer. Say your document is bad for me. So just fix this. And if you don't, then I'm not coming back to you like for that. I mean, it's actually very common sense. Don't think that this is surprising. I hear this often because
Well,
you start
the
reading
one
the
thing
document, questions come up
The
immediately.
one thing that I'm missing is I feel I do need to consult with a physician to understand better
Yeah,
these
so
different
you schedule,
consequences.
that's right. So you schedule a consult with a clinician to review. There's billing codes for that. There literally there's a code about counseling about end of life decision. It's a called decision making codes, and it's complete. You don't even have to have diagnosis for that. You can be completely healthy no matter what age you are, and you show up because you want to talk about this. It's a billable service.
I
Now,
tried it, didn't
now,
help.
now, finding a good physician to talk about
No,
this is a
yeah,
little different.
I tried, it didn't help. So,
Well, you can definitely try to schedule with me at MFA. I don't know how long it will take, but it doesn't look like you're dying tomorrow, so we can wait for that.
Can I
And number
also make a
two,
suggestion?
you can
Uh,
also look into any palliative care provider. It's
Yeah,
any palliative care
a
doc.
physician assistant, a nurse practitioner,
Exactly. Exactly. It could be
and
anybody with a palliative interest, and they don't have to be a physician. They're usually very, very savvy in all this. In fact, I'm not the best person about this by a mile. I mean, we have way better people at our department who do this for a living. So two.
okay. So look for a palliative care provider.
Yeah, and they don't need to like you don't have to find like a palliative division. You can simply look at the person's interest. You can ask around your own facility where you get your primary care and see if anybody has this interest, and then just schedule one-time consultation.
Okay,
It's a very and make sure you get at least 30 minutes with a provider, because obviously this is time intensive talk, right? Because you need time to just reflect and back and forth, write down your reflections and your thinking. It's very important. I actually so glad you brought this up. Now we're going to do this again in January. I don't think that it's not going to be a waste of time. I hope you come back and you may also get some additional information at that point. But it's a topic that we all have to face. It's a topic that we all not just have to face, but we have to do what you're doing. We have to spend time on this. It's sort of a lot of times people are just going to sign DNR. Okay, it's not that simple. we want to run through this topic like we run through a lot of things, but the problem is usually these issues, when they really come, they never come simple. That's been my experience. They always come with add-on complications, and you always struggle through if the document that we're talking about is not done very well, you know, and then you have this sort of additional. We actually have is B here? I don't think she's here. B, are you around? Oh yeah. Do you, Janet, can you unmute B? So we have a professional palliative care social worker who's retired now, who's been doing this work for 30 years plus. And, you know, B can also give us a couple of words of wisdom here. And I hope, B, you come back when we have Chris, because it'd be really good to also have you join the chat.
I just put in the chat that Brooke Meehan, who is with palliative care, she's a nurse practitioner. She has her own end of life planning service that you can check with her online. I'll get you the information.
Awesome.
And she's excellent with helping people sort of formulate a good events directive, because even 5 wishes is pretty daunting to do, and it's really, really hard. And so she puts it in really good terms in terms of how you can do one that is specific to you and your needs.
Yeah.
Thank
So
you.
the reason sometimes people say that 5 wishes is not advisable is because what B said, it's almost too complex. But at the same time, it sounds like what Rona is looking is really that level of complexity. And I actually think it's the right thing to do. I feel like you better spend more time on this rather than less time. And every document that's out there is never going to be fully complete for your own liking. There's always going to be questions, you know, and that's okay. Like, that's one thing to realize, that there's no rights and wrongs here. This is a top of a topic that is complex, very individual, and very difficult to open. But if you don't do it, there is a chance that the problem will be bigger at the end of it. You know, I will tell you that one of the most important things, in my opinion, we can do in our last decade of our lives is to set our death correctly. And that's actually why I'm bringing Chris here, because I feel strongly that we need to think about this. And Chris is very animated and very entertaining. So, you know, you will really enjoy him. I think we can talk about this topic without feel a little depressed and frustrated, right? And we can talk about this topic with a certain level of okayness and almost a joy and fun, right? Because yeah. All right. Is that the subtle sign, Janet? I had a bunch of other stuff, but okay, I can hold it.
Well,
I can hold it to other time.
do you want to do your other stuff after Mary Ellen?
No, there's nothing urgent, nothing sort of acute. I actually love that we did this because, you know, I had a couple of small things and they can wait. I just want to make sure we did questions. I haven't, because I got so excited I didn't keep up with the chat.
All right.
Yeah, and the Chris's book is out, so if anybody wants to buy it, it's in the link to the video. Thanks for. No, if you already have a medical advanced directives, that's fine. You don't need to redo them. They rarely change. I mean, sometimes people want to go back and look at particular aspects on the form, but if you already did one, you don't need to worry about that. Yeah, so I guess online services for this. B, is Brooke offering online services? No, right? I don't know if online service is good for this, because you need sort of, it feels like this is where you need a human being to interact. I'm not sure online service. I've never heard of that. It's an interesting question.
B, you're unmuted again.
No, she does it with you.
Online.
Yeah. Well, yeah, I mean, on Zoom or whatever, by phone, whatever. Yeah.
Awesome. Yeah. Yeah, so there's a standard forms in every state. Sometimes lawyers will just download whatever's in the state and give it. Sometimes they'll use what's like more of a general form. All of these forms are okay. They're all good templates. You can use any of them just as a starting point. It's always good to like if you go into a primary care and you have like an annual wellness visit, that's a very good time to talk about this. That's what annual visits are for. And you can bring your own form to the physician too. Like if you can simply run it by your doc if you feel comfortable about it. All right. Well, I don't see any other questions. And I'll oh, what's the difference? So DNR is a simply do not resuscitate. So DNR is one sentence. It basically says, if my heart stops, I don't want to be resuscitated. It has nothing to do in a sense with living will. Living will is a much more complex document. It will summarize not necessarily every detail. That's what Rona was trying to bring up, but it will summarize a lot of situations. Like, let's say you're in a car accident and you have to be on a long-term life support. Is this something you want? It will summarize potential things like, you know, you have a terminal illness, and do you even want to have any treatments for it, or do you just want to make it comfortable? So it's much more complex document that, particularly what's important about it, it points to your philosophy. And so I think one of the most important aspects of advanced directive is not necessarily list every scenario, but so that the clinician who is going to take care of you when they're going to need to look at that advanced directives fully understands your philosophy. They really know whether or not you're looking at some aggressive measures or is the priority or comfort. So that's one of the most important goals of the document, is to be very clear where is your comfort zones. Like some people will say, I will not, like, I don't want to do DNR, like I want to be full code, but dialysis, absolutely not. Like, so there could be a lot of really interesting differences in each document. All right, very good. I'll stop here. We'll hand it over to Dr. Kramp. Mary Ellen, thank you so much for coming. It's wonderful to have you here. Those of you who don't know, you're for special treat. While you're starting to talk, I'm going to post a longer video with you that we did, which, gosh, already a couple months ago, I feel like. And you all guys can take a look at the longer video, but meantime, we'll probably have about 20-25 minutes, 20 minutes with you, so we can get some of your wisdom that way.
All right. So he wanted me to talk about visceral manipulation. Most people have never even heard of that. I'm a physical therapist. I was trained at Springfield College in Massachusetts, very traditional PT program. Every PT program across the country trains therapists and everything about the muscles, the joints, the bones, the connective tissue that surrounds each of the muscles, the connective tissue, the ligaments that attach bone to bone, the tendons that attach muscle to bone. We learn all about that. We learn about the nerves. One thing we really didn't learn too much about, other than anatomy and physiology, was the internal organs, the viscera. So back in the 80s, a French osteopath by the name of Jean-Pierre Barral, he developed visceral manipulation as a treatment. And it sounds very harsh, but it truly isn't. I think it was more a language barrier thing, where in English it comes out as very harsh sounding, but it's a very, very gentle treatment. It's a way to treat those connective tissues and ligaments that surround and support the internal organs. They're not just floating inside our bodies, they're attaching to the skeleton. And they have a major impact on what our joints can do. So in PT school, we learn all about the shoulder and how the range of motion is in the shoulder and what motions we should be having and how to treat the ligaments, how to treat the joint capsule, how to treat the muscles, how to strengthen the muscles, all of that stuff. What we didn't learn was, if the pleura that surrounds the lung, it lines the inside of the ribs, if that is restricted, it doesn't allow the ribs to move. So the ribs should be moving out and up when you breathe in and down when you breathe out. And then you have the pectoralis muscle right on top of that. You have all these other muscles right on top of the ribs as well. And if those aren't able to move quite as they should, it's going to be much more difficult for someone to be able to move their shoulder. So a lot of times I will mobilize that pleura around the lung in order to get the shoulder motion to move better. So it's a very, very interesting concept. It's very different than, well, if it's, if the muscle's tight, you're going to stretch it. It's a different way of looking at the body. If the muscle's tight, my question is why? Why is that tight? What is causing that to be tight? So, for instance, another example. Here's the bladder. Here's the uterus. So the uterus sits right on top of the bladder. And every organ in the body has its own range of motion. So this uterus has its own range of motion. This bladder has a range of motion. And if this uterus is stuck, it's not going to allow that bladder to expand. So somebody say is coming to me and they are saying, I have to get up and pee every hour. Even during the night, I have to get up and pee every hour. Well, if it's a female and the uterus is, I find the uterus is really tight, it's not going to allow that bladder to expand. That uterus should be lifting up as that bladder expands and fills with urine. If that uterus is really tight, sitting on top of that bladder, as soon as this tries to expand, it's getting the urine on the inside. So there's some pressure on the walls of the bladder saying, okay, we're going to need to pee kind of soon because the pressure on top is adding more from that uterus. And it can also be, well, we're going to pretend these are intestines now sitting on top of this. The intestines can also be a problem and preventing that bladder from filling properly. So somebody who's telling me I need to pee every hour, is it because the uterus is really tight? Or if it's a male, is it because, or female, because the small intestine is not allowing that bladder to expand? So there can be problems with that. Because the bladder is also surrounded by connective tissue, it's attached to the pelvis, it can end up causing differences in hip motion. So the hips might not be able to move quite as well. So somebody may be coming to me with hip pain or low back pain because of the way this connects into the pelvis. So I can go in, and somebody who's having these issues, I can mobilize the broad ligaments. I can mobilize the connective tissue that attaches this uterus to the front of the pelvis and also back to the sacrum. I can mobilize that. So as the bladder fills, that uterus moves with it. So these have their own range of motion. So you can picture how things have to move, and that's just standing up or laying down. Now try to bend over and tie your shoe. That's going to change what's going on in here as well. You go to reach up. This all has to be able to move with you. If everything is tight down inside your pelvis, it's going to limit potentially how well you can reach. Or if you have a lot of tension within the pelvis, within the abdomen, or within the chest, as you go to reach, yeah, when you're younger, that may be easy to do to kind of overcome that tension. But after a while, it's like all of a sudden you get a rotator cuff tear because you're fighting that tension that's in your body. So there's a matter of, okay, the shoulder's tight. Why? Was it because of something going on in the pelvis? Was it because there was tension around the pleura and the ribs couldn't move and allow the muscles to contract the way they need to and allow things to glide the way they need to? So there are a lot of different things that can be going on within the body that can cause a lot of different symptoms. So anywhere from, I've done research personally in infertility and using physical therapy to treat infertility from a mechanical perspective. So from the perspective of the infertility center, they're wondering, okay, is this woman producing eggs? Is this is there restriction within the uterine tubes? Is there restriction or problems within the uterus itself? What's the hormone production? And so they look at everything from that. I look at everything from a more mechanical perspective of how can I treat this body so so this is optimal. So all I'm trying to do is optimizing the environment. Can I mobilize the uterus so it's sitting in a good position? You have the blood flow coming into the uterus through this connective tissue. If this is torsioned, say I had a patient who used to ride horses when she was younger, got thrown off horses repeatedly. Her sacrum, the bone at the base of the spine, was stuck. And the connective tissue that allows this to sit well within the pelvis was then rotated. So was it a matter of that rotation maybe kinking off the uterine tubes, which are really, really, really small? So my treatment was to just mobilize her sacrum, mobilize the connective tissue in here, and she was pregnant the next month. Of the women that I treated, about 60% became pregnant within 3 months of finishing up the treatments, which were usually between 2 and 3 treatments. So there's a lot of application that PT has as far as treatment of bladder dysfunction, treatment of bowel dysfunction, treatment of back pain, neck pain, shoulder pain, all of that by using visceral manipulation to manage the body. For another common issue is like neck pain after a car accident. So you'll see people with a forward head often. Sometimes it's from a car accident, sometimes it's not. But there might be somebody with a forward head. In PT school, we learn to, okay, bring back, bring the neck back, bring the neck back, work on your posture, work on your posture. Well, if you look at from a visceral perspective, there's the heart that's surrounded by connective tissue called the pericardium. That pericardium has ligaments that attach it to the sternum in the front. It has ligaments that attach it to the neck as well. And if those become tight through a whiplash injury, the body's going to want to hold in this position because those ligaments are going to be tight. So you can, try to teach someone how to bring back, and try to maintain a good posture. But until those ligaments are released, it's not going to be easy for that person to just maintain that posture. Posture should just be ease. You shouldn't have to work to be in a good posture. So if you have a posture where it's really tight, on the inside, and those internal ligaments, it's going to be very, very difficult for someone to be able to maintain that posture. And I see from Roni here, endometriosis causing pelvic organs and other organs too to stick together. And yes, that can cause adhesions and things to that connective tissue to stick to each other. And this treatment isn't going to melt the connective tissue. What it's going to do is to help mobilize that connective tissue. So that connective tissue can glide better on, the bladder, be able to move on the uterus, the rectum on the uterus as well. That the small intestine doesn't have to be stuck down. It's not going to be you can't melt scar tissue. If you think of a scar, say you have a scar on your arm, you're not going to melt that scar away. That scar is going to be there. It's just a matter, is it going to be rigid or is it going to be mobile? So it's a way of working with the body to get those tissues to be mobile. I'm trying to look at some of the messages through the chat here. All right. What role might scoliosis play in my work? Well, it's going to be a matter of what is causing the scoliosis. Scoliosis is, there are a lot of factors that go into scoliosis. And, it also depends on age. So if I got somebody young where it was just starting, yes, I'd be able to work with a lot more versus somebody who's, say, 75 and has scoliosis. There may be a lot of restrictions in through the pleura and the pericardium, not allowing those organs to move, making it difficult for that person to be able to take a deep breath. And those people, yes, I can improve things. Am I going to change a scoliosis significantly in someone who, say, is in their 70s? Honestly, no, I'm not going to be able to do that. But am I going to be able to make it easier for them to breathe? Yeah. Am I going to make it easier for them? Maybe I can work with the reflux that they might be experiencing because of increased pressure throughout the abdomen. So I can help to mobilize that as well. So, maybe I can improve reflux, I can improve breath. I can, if there's a diarrhea, constipation component, I can sometimes improve that as well. Okay, got another question. I have a forward neck. How would you work with this? And can the person learn to do manipulations to loosen the connective tissue on themselves? It is difficult to learn to do this to yourself. One of the ironies of knowing how to do this work, I know exactly what to do, and it's still very, very difficult to do it on myself because of the positions I would have to get in, knowing the handholds, knowing the anatomy. With forward neck, I would be working on the tissues typically around the pericardium, the pericardial ligaments, to get that to mobilize. There are also other techniques that aren't visceral manipulation that I would be using to see what would be causing someone to be in this type of posture, because there can be restrictions and through the hyoid and the esophagus and the vasculature that can also create that forward neck. And let's see. There is an organization of PTs where you can find this out. The organization is, let's see, I'll put it in here. Let's see, www.iahp.com, and you can, there's a find a practitioner portion on that. And if you put in the first three numbers of your zip code, it will give you practitioners in your area, and you want to look for somebody who does visceral manipulation if you're specifically looking for that. All right, I could talk about this for about 20 hours. So if anybody else has any questions, I will be happy to take questions.
There are a few questions in the chat, so I don't know if we covered them.
Okay, yeah, I've been covering them as I've been going along. Okay, is this like Rolfing? It really isn't. Rolfing is more of a 10-step. And they are staying really within the musculoskeletal system. This is working on the connective tissue within or around the internal organs and making sure that each organ is able to go through its own range of motion and not limit shoulder mobility, rib mobility, pelvic mobility, hips, and so forth. Let's see. What's the favorite aspect of your work? Your favorite kind of problem to treat? Ooh, I like so many things. One thing my newest project right now is working with postpartum moms and their babies. I'm working on a project called Breast Baby and the Difficult Latch. So these are babies who are having a difficult time getting onto the breast or taking a bottle. And so I'm using visceral manipulation in some cases where the baby may have been really stuck in utero, and they are really locked down on, say, one side of their body, and they can't get that side of their body straight, and they can't turn and be able to latch onto a breast. So working with those infants, and it is so quick working on a newborn, and seeing the differences with how quickly that they can improve. All right, so we've got a few more questions here. Let's see. So somebody said this really helped them with their digestive issues. How many sessions does it usually take to work on a problem like the shoulders or neck? And does it need to be ongoing to keep it from coming back? That's a very good question. It varies. It varies a lot. Some people I can get things done in one session. Say somebody who's coming to me and they've had this problem for 20, 30 years. It's going to take several sessions because there can be so many different things going on, and it often goes beyond visceral manipulation, where I have to pull out a lot more tricks out of my bag. And yeah, it can take several sessions because it's a problem area. Do I need to keep working on it? Not necessarily. Every once in a while, an area might need a tune-up, but it's not like I need to see you weekly for the rest of your life. And what difficulties might practitioners encounter in general with someone with EDS? So Ehlers-Danlos syndrome, hypermobility syndrome. Even somebody with hypermobility, they can still have a lot of areas that are very tense. So one thing with that connective tissue, it has a contractile property to it. So one thing we see frequently at ThriveAgain is postpartum patients. And the postpartum women will often have issues with the uterus or bladder or rectum falling down in the pelvis. The abdominal muscles might be more separated, and this is very, very common with our postpartum EDS patients. And even though everything is really lax, I am still using the visceral work to get everything to become more supportive again. So the connective tissue has contractile property to it. So the connective tissue can either be really tight and rigid and causing a boatload of pain, or it can just be off and then it's not supportive at all. And so there are usually areas of restriction elsewhere that is causing the that connective tissue to be off. So in those EDS patients, a lot of times it's finding the magic buttons to get that connective tissue back on to be supportive again. Yes, that is an Oura ring. Yes,
It's a
I do.
great tool.
I love it. I love it.
Yeah.
Very, very, very helpful as far as it's telling you how sleep is going. It's a reminder to stay active. It's a reminder to rest. It will kind of give you some clues when your body's kind of teetering and you're not quite feeling so good, even before you may realize it. It's a quite interesting little tool.
It's a great piece of equipment for anybody who wants to track anything. Let me make myself visible too. And one thing with all the variable devices, most of them are quite bulky. So they're Apple Watches and all these wrist devices. They're quite into your face, and you really can't turn them off. The Oura Ring, you can put it on airplane mode with 0 EMF, and it will actually still collect the data. That's the only piece of equipment currently on the market that does this. Everything else, if you worry about any exposure to any vibrations or frequencies, there is no other choice but Oura Ring. So that's one. And the only thing with Oura Ring I find not good is the heart rate during exercise is not realistic. It doesn't track it well. So, all right. So let's do the practice for a couple of minutes. And Janet just texted me saying that her computer ran out of juice. Mary Ellen, thank you so much. Thank you. I hope you'll come back in a while. Sounds like there's so much interest in what you have to offer. We'll have to have you back in 6 months or something like that. So thank you.
Thank you.
So upon popular demand, I think that some of you have been talking to me and asking me about this weird Buteyko method. You guys familiar with what I'm talking about? I think those of you who have read The Breath by James Nestor, of course, have read the whole chapter on the Buteyko method. But those of you who have not, you know, you are guys for a new practice for yourself. So go ahead and make yourself comfortable. If you need to lay down, it's highly advisable. So if you get off the screen, that's perfectly fine. It is important that you as relaxed as possible. So if that means you need to lay down, do so. First, what we're going to do, we're going to check, so get your Apple Watches, pun intended, get your clocks or whatever it is that measures this. You need a stopwatch, so you have to measure your current capacity to hold the breath on exhale. So what we're going to do is we're going to take a gentle inhale. We'll do it a couple times and then I'll tell you. Let's do it now. Then exhale. So when we're going to do the actual cycle, when you do that gentle complete exhale, you're going to pinch your both nostrils, hold your breath, start the watch, and see how far you can go. You're not to push beyond the sort of limit. You need to go until you feel this is comfortable. Now I'm not feeling comfortable. I'm going to take a breath and I'm going to stop the stopwatch. So let's take another breath. And after this breath, we'll start. So inhale, exhale, and one more. Inhale, exhale, pinch nose, and count. Begin. So I barely did 25 seconds. I wonder who else got what. By all means, feel free to type it in. Let's see if anybody got to a normal range, which is considered 45 to 60 seconds. That would be considered normal. I'm yet to see a single normal person who has not practiced this method. This is exceptionally useful if you're a swimmer. If you're a swimmer, you're going to love this practice that we're going to do. Why is this important? I mean, if you take a deep breath and then you try to hold your breath, most of us can probably get close to a minute without any special training. But the importance here is that you, believe it or not, it's on exhalation that's really critical, because that's when you inhale, you stop, you're really gasping for air because of the, your CO2 buildup. When you exhale CO2, and then you're really trying to inhale because your oxygen is running out. So there's two differences. When you take a deep breath, you inhale a lot of oxygen, and so you hold it longer because the oxygen is circulating, and then the CO2 is beginning to rise. But it's actually essentially more important to learn to hold your breath on exhale. So let's start with the practice. So imagine that you're kind of anchoring onto the earth. If you're laying down, just think that you're laying down on the earth. You're sitting down, feel your feet touching the earth. So now kind of connect through the feet or the back into the earth, and begin to imagine how you go into this connection deeper and deeper. And now we'll begin to inhale on count of 3 and then exhale on count 6 of 5. So you're prolonging your breath a bit more. We'll do that for about 2 minutes. So inhale on 3 and exhale on 6. Okay, one more 3, 6. Okay, so now we're extending to 4, 8. So we inhale on count of 4 and exhale on 8. Keep going. So we'll do a couple more breaths, maybe 3 more. Okay. Keep going. So now we're going to move to 5, 10. If you move to the, and keep going, just listen to my voice. So if you got to 5, 10 and on exhalation you begin to struggle, then you stay at 4, 8. Okay, if not, you continue with 5, 10. Make sure that every breath is not deeply forced. If you're really struggling in any moment on inhale or exhale, go back down 1 count and practice the breath that's comfortable. So let's go to 6, 12. If you're feeling at the end of exhale, you're really struggling, drop down to 5, 10. So your exhale will be for count of 10. Now we're going to do one more. So now we're going to 7 and 14. So if you're struggling, drop down to 6 and 12 or 5 and 10, whatever it is that's comfortable. And then we'll do one more cycle and then we'll close with something else. last breath. So now we're going to simply repeat. So you're going to take a regular inhale, regular exhale, and then time yourself again. So let me give you one more since I dropped my clock here. Okay, so inhale, exhale, close your nostrils, and begin. So I added 5 seconds up to 30. So usually you'll find at least a couple of seconds up doing this. So this is a very simple practice. You keep stacking it up as much as you go. So you go up. Wow, CJ, from 24 to 36. That's really cool. That's a good jump. So you keep stacking it up as much as you can. So if you can get to 20, 40, that's great. You can get 30 to 60, amazing. So there's no endpoint. So that's a very simple one of few Buteyko methods. Basically, in principle, what you're doing here, you're gradually training your system a slower and longer exhalation. That's all you're doing here. And there's some other Buteyko methods, but this is one of the easiest. It's a starting point. It's a great practice. You have some 10 minutes on the bus, can easily do this. Yeah, sure. It's Buteyko. And if you read, I strongly recommend everybody to get James Nestor's book. He has a whole chapter on this method. Buteyko had his own books and all, but he's dead a long time ago. And I think it's not easy to find his original works at this point. All right, we're just a minute over. I'm gonna ask Elisa Parker to unmute. I'm gonna highlight her and tell us a little update on something related to our AIM Health Institute. Those of you who don't know, Elisa is our vice chair of AIM Health Institute, vice chair of the board. So she's here in her formal capacity, and also, wait a second, why is there two? Sachi, why is it says that you're Elisa Parker too? And we also have another board member, Sachi, who I added to highlight. For some reason, she also shows up on my screen as Elisa Parker. But anyway, so you ladies give us an update real quick over a couple of minutes. Oh, you can't unmute, can you? How about now?
Okay.
I can unmute.
Okay, great.
I would like to turn it over to Sashi, who is responsible for doing a major volunteer project for AIM Health Institute for Misha and all of us. And Sashi is wonderful, so please help her. Take it away, Sashi. Explain what you're trying to do. Oh, I think she's mute. Now she's mute, Misha.
Okay, try now.
Can you guys hear me okay? I'm in a cafe, so I just want to make sure.
Yeah,
Okay. Yeah, so I just joined AIM a few months ago, and I'm doing a marketing social media revamp of the entire organization. And we're looking for some volunteers to do social media stuff, especially because we're doing a fundraiser in a few months with Misha. And I've already created like a LinkedIn and an Instagram, and we just really want to make sure that there's a foundation on like in terms of social media presence for AIM before we start heavily marketing the fundraiser that we're doing. So I'm hoping in the next 2 weeks or so we can get some volunteers that can help me out with like creating like content or like having posts and stuff, because as long as we have like, I'm thinking we should have like at least some posts before we start doing the fundraising posts. That way it looks like we're a legitimate organization that has been doing a lot of work the past few months or the past few years. And yeah, I'm specifically looking for like Instagram and Facebook, or just like even blog content so that we can use that on the website. But like any help would work. It's just I cannot handle all this by myself. So literally any help, I'll take any. Yeah.
So if you're interested in helping out, you can put the name in your email here in the text now. You can also email to Janet or me directly, and we'll make sure we'll connect you to Sachi and Lisa. Thank you, everybody, for coming. We'll remind you also about this in an upcoming couple of weeks. Janet apologizes, her computer ran out of juice, so we don't know who's going to be doing next week, but somebody will be. And so, yeah. If I'm going to stay here for at least 5 more minutes, if I'm going to stop recording now.